Welcome, everybody. We're about to start this very interesting webinar on the vaccination process within the sector of services for people with disabilities. Welcome to this event. Before passing the floor to Luc Zelderloo, our Secretary General, for some opening remarks, I would like to give you a few technical details. The webinar will be recorded and made available after the event, so it's also possible to share it afterwards. Your microphone will be muted to ensure the quality of the session. Of course, what we're trying to do is to have also a very interactive session. We have many key experts here coming from all around Europe to bring in their expertise. So if you have any questions and you have any comments to make, please could you write them in the Q&A button at the bottom of your control bar. If not, there's also the chat box. But as that sort of people speak quite often there, it's harder for me to find the right questions. So preferably, if you have questions, please write them in the Q&A box, if not in the chat box. One last point also, we have closed captioning, which means that we have written speech to text, which is available. So if you want to have that, please click on the closed caption button at the bottom of your screen. And then I will do it myself to go through the process, and then you show subtitles. If you do that, you should have subtitles in English at the bottom of your screen. So now we've done that, let's move straight on to the content. Luc, the floor is yours.
Thank you very much, Thomas. Dear colleagues, dear friends, I'm Luc Zelderloo, Secretary General of ESPD, and it is my pleasure to welcome you at this, I think, very important and very interesting webinar. We thought for a while, right after summer, that indeed our special efforts to bring the sector together to exchange ideas, approaches, models of good practice with regard to COVID-19, well, that would be over. But we see now that it is far from over. We see across the European continent, again, infection rates rising, and we see more and more unrest also in society with regard to the measures implemented by authorities. So the COVID-19 crisis is far from over yet. And that is why ESPD decided to again start with this organization of webinars. Every 14 days, we invite you on Wednesday afternoon for a discussion on important, relevant issues with regard to our role in this COVID-19 crisis. So it is with pleasure that I see that again, many sector leaders are here with us today. A warm welcome, a warm welcome. Today, the focus is on vaccination. The vaccines are there. They prove to be very effective. So there is a bit of light at the end of this COVID-19 tunnel, although it also stirs up a lot of emotional reactions and triggers many, many difficult questions. Of course, we are grateful to the European Union that so many million vaccines were bought at a cheaper price. That is, I think, very good news. But we also see that this brings many, many challenges. On what we would like to focus here today is, what does vaccination mean for our sector? What does it mean for the social care workforce, for the professionals active in the field, but also for the persons, for the people that we try to support? The Commission has set the bar quite high. They hope to vaccinate 80% of the health and social care professionals by the end of March 21. And of course, they all aim together with our authorities at a 70% vaccination, if possible, before summer. Whether all that is realistic and feasible, that will be, that is maybe for later. But today we want to focus on how should this vaccination go? What are the difficulties? what are the problems that we might face as social service providers. And of course, we cannot look at our workforce without also taking the concerns of the people supported in our services into consideration. And that is why I'm so happy that we will be able to present to you today also a very practical tool in easy to read, in easy English, so to say, but we have it available in many different languages, I should say, an easy to read document that we developed together with Inclusion Europe. Inclusion Europe, that is the voice of families and persons with intellectual disabilities at European. We will look at how to organize vaccination when we are involved ourselves, and how we can facilitate things for our service users and for us. Why should care staff and people supported be prioritized? How can we do it in the right way? What considerations are important? How to communicate about COVID-19 vaccination? And this is where this easy to read material comes in. How to facilitate the deployment of the COVID-19 vaccines. All these questions will be discussed today, and we have, as a point of reference, a good overview. That is the work of the policy team led by Thomas Begnell. We have a quite good overview of what is about to happen in different countries, how they prioritize and how they want to implement an effective vaccination strategy. Many questions, but also many good speakers. And I'm sure that every one of you is interested in this topic and is willing to contribute. Like we did before the winter break, we will collect models of good practice. If you want to share material with us, approaches with us, please feel free to send it to us now during this webinar or afterwards on our relevant email addresses and Facebook page. And we will try to make this available to the wider social services sector. And so we can learn from one another and support one another. Without further ado, let's dive into the issue. Vaccination. How can vaccination bring our so-called normal life back to us? And how can we make sure that the right people are vaccinated at the right moment so that they do not become the victims of this terrible virus? Dear colleagues, I wish you a very interesting afternoon and a very enriching exchange of ideas. Over to you, Thomas.
Thank you very much, Luc, for, I think, a very thorough overview of the situation right now. I'm sure there are many questions, but we will try and first of all solve some of those questions through our expert panelists. Before I start that, just to let you know that Luc mentioned that we have developed an easy-to-read paper on the COVID vaccination with Inclusion Europe, available in, I think, 10 or 12 languages. And I've just shared the link with you to access this paper. Please feel free to share it broadly. And as sure we will talk about it later, but it's important to make sure that people take decisions informed about what's happening in the process.
And it's copyright free, yeah? It's for free. Yeah?
It's for free, yeah, of course. Thank you, Luc. So moving on now, we have two different panel discussions. The first is more looking at the issue from a cross-European perspective, and the second will focus more on the deployment of the vaccine at national level. So first of all, I would like to introduce Dr. Edoardo Colzani, who comes from the European Centre for Disease Prevention and Control, and they've been very, very active in trying to facilitate the discussions, the processes across Europe. And I will let him explain the work of the centre himself. Edoardo, the floor is yours. You have around 5 to 6 minutes.
Thank you, Thomas, and good afternoon to everyone. I will share my screen so that you can follow my presentation. So I will give a brief overview on our report that we published in December on vaccination strategy and prioritization for the European Union and the European Economic Area. Just to consider that we use a modeling approach, so we wanted to be as quantitative and as objective as possible. But of course, we also outlined a series of principles and considerations that also need to be taken into account by countries when they want to implement the strategies and their prioritization objectives. I will start very briefly by saying that it's important, first of all, to really set up clear objectives when it comes to strategies. And these objectives, they may not be necessarily alternative to each other, but they could be sequential as well. And they may be affected over time by a series of other events that may, of course, can change the rapidity, the efficiency, and also the choice of the objectives that we may want to talk about. And this is important to keep in mind, because one of the main principles that we try to communicate is that any vaccination strategy, given the exceptional circumstances that we are in, need to be in a way adaptable. So you need to be clear, obviously, but they need to be adaptable, because unforeseen events may occur, and therefore they need to be tweaked and adapted to the new upcoming situation. Then, not to go too much into the details, but we try to identify some general, non-mutual exclusive approaches or principles where you can basically base your strategy upon. You can focus on selected groups of individuals, and there is a list, of course, of these groups that can be selected. You can vaccinate according to age strata, or you can target groups that are at increased risk of exposure and then onward transmission to other vulnerable groups. Or you can prioritize based on other type of consideration, like geographical regions with higher incidence, or to control outbreaks, or even to go for a mass vaccination when you have enough supply. I will not dwell into methodology because I'm aware of the time that is quite constrained. So forgive me if I jump a little bit on these parts and also on part of the results, but I'll be happy to take questions if there are any specific ones. Basically, what we did, we tried to compare different scenarios of let's say mock-up vaccines and characteristics, and also approaches, basically based on targeting different age groups and including possibly healthcare workers or people with underlying conditions. And we try to compare each of these approach to a baseline situation where you would vaccinate all adults in the population. We say adults because at the moment the vaccines are licensed only in 16 plus or 18 plus years old individuals. So that's the population where it's possible at the moment to vaccinate. As you can quickly see from this graph, for instance, we can show that in terms of effectiveness, if you look at the A part of the graph, you can see that just by vaccinating people in orange that are 60 or more years old, you may capture almost up to 90% of all the deaths that you may avert by vaccinating all the adult population. This is an important consideration, for instance. And if you skim through the other results, you can see many other considerations. If you look below in terms of efficiency and at the C graph, you can see that it could be much more efficient in terms of number of deaths prevented by number of doses of vaccines given to vaccinate people over the age of 80, because that's the age group where you have the highest density of deaths, for instance, and hospitalization. Well, not really hospitalization, but definitely deaths. So all of this is been part of what we did. We did it also, as you can see here, for healthcare workers, and to basically also include here is people with preconditions against people with older age, and you see that you may have some additional gain by including people with underlying conditions at risk for severe COVID-19, on top of the age group, but sometimes this added value might not be as big as one may wish. So this is just to inform decision makers about the potential added benefit and comparable benefit of the different approaches. Same here for healthcare workers. This is important to highlight the fact that actually, if the vaccines have any effect on the transmission, we know that the vaccine prevent very well the disease, but we don't know yet if they prevent the transmission of the disease. So in healthcare workers, it is quite clear that it's extremely important that the vaccines may work also against transmission, because they are in touch with vulnerable individuals and patients at increased risk of death. So the more a vaccine may prevent disease transmission, the better would be the value of vaccinating healthcare workers, social care workers, and all the people who are in touch with vulnerable people. It doesn't say that it's not valuable to vaccinate these people as well for their own individual protection, because there are other considerations that we can make, but it is also important to know that they can indirectly protect more vulnerable populations. And this is, well, the last one about the adult population, but I will not go too much into this. In terms of practical considerations, it is important to know, and we all know very well, that the demand as of now exceeds the supply, and this may be so for a while. So it is very important to manage the expectations at the all level, in particular through appropriate communication about objectives of different phases of the vaccination, objectives that can be targeted as well to different groups that may be eligible for vaccination, because this is really important in a phase where we are still not having as much as we would like. And then there are also other factors to consider for building vaccination strategies that I did not mention, but they're as important, which are, of course, an equity and also access considerations, I may add, safety and efficacy of the data available in potential target groups. The clinical trials for vaccination licensing did not and could not focus on all possible groups, so we need to consider also carefully that these groups, they have sufficient data for being prioritized. And then logistics, vaccine acceptance in different target groups, and also what is the current headache, the potential emergence of new variants that may escape the immune response induced by the vaccination. To conclude, in our document, we basically said that it's important that the prioritization of COVID-19 vaccination and the strategies take into account several dimensions, including the context where the vaccination is done, meaning the country, the region, and all the social and contextual aspects that needs to be taken into account. It needs to be adaptable, as I said at the beginning. And also it needs to have clear objectives that may be modified over time according to the ambition that we can move the target a bit further. Now a bit still of an emergency situation, so the priorities are really to save the hospitals and save the ones who are at the highest risk of dying, but then of course over time we can become gradually more ambitious. If a vaccine does not protect against transmission, as I said, the most effective and efficient approach is to prioritize in particular the vaccination of the groups at highest risk of severe disease and death. Another important conclusion is that substantial reduction in mortality and pressure on the healthcare system could be achieved by the direct protection of high-risk groups, because these people are the ones that unfortunately more often end up in the hospitals and hospitalized. So you would get a double benefit for the individual, but also for the healthcare. And then there is also the consideration that the vaccination of healthcare workers, and we can expand also to social health workers to some extent, it's very important because would be heightened by the vaccine if there were, as I said, effects against infection and onward transmission. So it would offer indirect protection to all the patients, but also residents of long-term healthcare facilities and other high-risk individuals that needs assistance. And then finally, although vaccinating the adults that are not older adults is not considered at the moment the most effective and efficient strategy, we should still give some consideration to specific groups in these age groups or settings that may have a disproportionate exposure, or they may represent individuals at medically or social high risk of severe disease. And with this, I finished the presentation. I hope I didn't take too much time. And I also thank my colleagues who contributed to this report. Thank you very much.
Thank you, grazie, Eduardo. I think a very clear overview of the situation. I will now pass the floor to Gerlinda from Inclusion Europe, but if there are any questions, please don't hesitate to put them down. I received several from participants beforehand, so if there aren't any questions here, I will have some, but it is better if you ask the questions in the Q&A box. Gerlinda, you represent Inclusion Europe, which maybe you can introduce first. And then we asked you, sort of, from your perspective, what are the main recommendations you would give to service providers, policymakers, etc. You have around 5-7 minutes. The floor is yours.
Thank you. Good afternoon, everyone. Thank you for inviting Inclusion Europe to today's webinar and discussion about the vaccine deployment. I'm Gerlinde Schmidt. I'm a policy trainee at Inclusion Europe, the European movement of people with intellectual disabilities and their families. Today, I will be speaking about the COVID-19 vaccine and legal capacity. While speed and efficiency of the vaccine rollout are currently vital to protect and save lives, the issue of informed consent and legal capacity becomes of central importance. The right to decide and to legal capacity is a right that is enshrined in Article 12 of the UN Convention on the Rights of Persons with Disabilities. And it is also, and the right to make decisions is also very important to take to access many other rights, for example, the right to vote, and in this case, the right to decide whether to get the vaccine or not. Accessible information plays a vital role in order to take informed decisions. Over the last year, Inclusion Europe conducted a research into how COVID-19 impacted the rights of persons with intellectual disabilities in Europe. And we have found that the COVID-19 pandemic highlighted the compounding structural weaknesses in protecting the rights of persons with intellectual disabilities. And this we have also observed in regard to legal capacity. This has been largely due to, especially in the beginning of the COVID-19 breakout, the absence of accessible information, which has led to confusion and also impacted the right to decide and take informed decisions about measures, knowing your rights and entitlements. And therefore, it is very important that we provide accessible and accurate and fact-checked information to people with intellectual disabilities, especially now in the beginning of the deployment of the COVID-19 vaccine, so that they can take informed decisions and also know that they have the right to decide. This information is very important to be provided in easy to read. Easy to read is making information easy to understand for people with intellectual disabilities, just like the document we just launched now in the beginning together with ESPD. If you want to find out more on how you can make easy to read information, have a look at Inclusion Europe's website, but I also enclosed to this PowerPoint presentation some useful resources that we can share later on. So currently, there seems to be a lack of accessible information about the corona vaccine available, and there's also a lot of differing information. And this needs to be combated basically right now, and accessible information has to be made available to inform people about their rights. But it's also from the same importance to that doctors receive training in advising and not coercing patients into taking the vaccine, and that service providers act as a point of trust and support decision-making of people with intellectual disabilities. And yeah, and this is and any information you are providing and disseminating must have at heart the right to take decisions, and that people have a choice whether to take the vaccine or not, and that all the important information is being communicated before people take the vaccine, for example. And it's also likewise important that people living with their families or living in residential care homes under guardianship or living independently are reached by this information. While we're just at the beginning of the COVID COVID-19 vaccine rollout, we have already observed some issues, which in regard to time, I will not dive into, but it's basically about really making sure that people are informed about what it means to take the vaccine. For example, that you can't, in the Galician region, people couldn't see their family for 4 weeks between the first and the second vaccine. This has led to a lot of confusion for people in residential care homes. Or for example, also that people need to know beforehand if they can bring, for example, their support person with them to vaccination centers, that vaccination centers ensure reasonable accommodation, but also that procedures to book vaccines are accessible. There have also been already some good examples of how to make information accessible and increase informed consent and informed decision making. For example, Luxembourg published infographic and podcasts about the vaccine. France published information in easy to read. In the United Kingdom, the government published an accessible website. Also, ESPD and Inclusion Europe, as already mentioned in the beginning, and we have together made an easy to read document about the vaccine and legal capacity, which informs people about the procedure of getting a vaccine, and also that they have a choice to decide. I invite you to all take a look at it, disseminate it and use it, but also feel free to look at it as a kind of sort of guidance if you want to create your own easy to read documents with rather country specific details. This is a very good example of how to make information accessible. Now I'm coming to the end of my presentation, which I will close with Inclusion Europe's recommendations for service providers. They're fourfold. The first recommendation would be to ensure the information and any information campaigns are accessible for persons with intellectual disabilities, for example, through providing easy to read information, and as well as inform people about that they can take own decisions. The awareness raising of the COVID-19 vaccine must actively involve people with intellectual disabilities, their organizations, and their families. This way, you can, for example, also reach out to people that might be not so well connected to self-advocacy groups, disability organizations, etc. The third recommendation focuses on free choice and informed consent. So all COVID-19 information you're providing and campaigns must inform people about the free choice, about taking the vaccine, and must also especially reach those placed under guardianship. The last recommendation is the consultation of people with intellectual disabilities in all decisions affecting them. So for example, if you write an easy to read document, let a person with an intellectual disability proofread your document, but also consult people with intellectual disabilities about what kind of information is needed and what is the important information that has to be communicated. Yes, this is it from Inclusion Europe side and from my side. I'm happy to discuss any questions of yours. If you also want to write me an email about a more rather specific question, feel free. I have attached with my team 2 slides with, I'm not going to go into depth, about accessible resources about the COVID-19 vaccine and about the COVID-19 in general from Inclusion Europe members, but also other disability organizations in Europe, which I invite you to have a look once we share the PowerPoint with you. Thank you.
Thank you very much, Gerlinde, for, I think, very precise overview of the situation, some clear recommendations for us as well as service providers that really points us in the right direction. I will quickly, before moving on to maybe some questions, share with you how to find the easy to read information that we developed with Inclusion Europe. I'm sure it would also be available on Inclusion Europe's website. And we have the document available in English, Romanian, Greek, Dutch, Spanish, Italian, French, Macedonian, North Macedonian, Bulgarian, Slovenian, Russian, and German. Of course, these are sort of, to a certain extent, the languages that we had available to us internally. And we are really on the lookout for people who would be willing to translate it to other languages and to make it available broadly there. So please contact us if you're willing to help us for that. We're trying to reach as many languages as possible. And also please use this as much as possible, share them at national level, and hopefully they can be of help. they're based and inspired from existing easy to read information, but also from, let's say, internal experts that Inclusion Europe have themselves. Great. So I will now stop sharing that, and I will come to a question that was asked to me beforehand with regard to you, Mr. Golzani. Do you have any news, for example, on the extent to which extent do the vaccines prevent infection and broader infection? Because we have many of people who work in our sector are social care workers who work in residential institutions or in community facilities, so forth. So of course, this plays a very major role for them. Do you have any internal news for us about that?
So at the moment, there is no news on that because, as we know, in the clinical trials, this could not be assessed. So the vaccines are being approved without assessing the effect on transmission. This is nothing strange. It's something that happens regularly because they get approved on the basis that should be protecting the person who received the vaccine. And of course, we need studies, and we need studies that will be able to continue. Can you hear me well? I saw that there is.
Now we do a bit better. At the beginning, not so much.
Okay, shall I repeat?
Yes, please.
Yeah. So as I said, from the trials, there is no information on the effect on transmission, but this is normal because the trials and the licensure process are for the assessment of the efficacy of the vaccine on the individual who received it. That's what it is licensed for, and not on the effect on other people. That is more a public health question, and therefore it comes later. It's not a question that comes at that stage. So at ECDC, we are in the phase of setting up studies that will look into this, and we are really in touch with all our partners to study specifically, especially in the hospital environments through our networks, what is the effect on transmission. What can I say without having any data to support it is that if the efficacy against disease is so high, confirmed by further assessments, there is also an expectation that there should be some effect on transmission. Of course, this is not so obviously so, but I have, this is personal opinion, a reasonable expectation that there is some effect. And we also know from our modeling study that even with a moderate effect on transmission, it makes a huge difference at the population level in terms of indirect protection. We were as lucky as we hope and we think to have at least some moderate effect on disease transmission, then we can clearly have some stronger indirect protection associated to that. Nevertheless, at the individual level, of course, is another discussion, because if it's 20%, then it is 20% against transmission, is not more than that. But at the moment, we don't know if and how much it works against transmission. That's the short answer.
Thank you, Eduardo, for that response, and for also giving your personal opinion. I know it's always difficult, but that's, I think, very important news for us to hear, that there is some potential there. Another question I received from Spain yesterday, actually, and it involves the ECDC, is that because of the modeling that you use, it's very difficult for you to include, let's say, data on people with disabilities. Does this mean that you haven't worked on the issue at all, or has the topic come up? Do you see different groups, categories within people with disabilities? And maybe the last question is does the ECDC plan to work on it a bit more in the future?
So there is a plan. So ECDC did last summer a guidance for, let's say, how to support vulnerable people, medically and socially vulnerable people during the pandemic. Of course, that guidance did not involve at the time vaccination, because it was not yet there. Our work recently on vaccination has been focusing, as you saw, on the big picture and try to see, because we are in this emergency situation. So the very first priority was really to understand in the bigger frame how to best roll out the vaccine in an efficient and effective way, and in particular to really spare hospitals and people who are indeed in the front line of all these crises. Now we want to look a little bit more. There are colleagues of mine that they are also looking a bit more into vulnerable groups in general from the previous experience, but also now specifically, and they will work with us on that. The problem we have at ECDC is that since we cannot collect with the resolution that countries may have information on people on disabilities, who are also a very heterogeneous group, and from the point of view of response to vaccine and the point of view of it, solution to be able, and I'm not aware also in the literature that currently there are enough studies that are looking at specific disabilities per se. I mean, it was shown from British data that there is, of course, this group is vulnerable and is overrepresented in the severe COVID patient. But of course, in order to be able to provide some more useful practical information on the vaccination, one would need a bit more resolution. And for that, ECDC, from the quantitative perspective, is unable to work, but we can work from other perspectives, and we are planning to do so.
Thank you, Eduardo, for that response, and I'm sure that ourselves and I assume also Inclusion Europe would be willing to help on your work in that regard. One maybe last request, if you could bring it back home, would you, and maybe we can, of course, it's difficult for you to answer now, but it would be good if we could discuss with your colleagues to make our easy to read documents available on your website, on the ECDC website, and maybe something that we can discuss to make sure that also the information that you provide is also accessible for people with learning or intellectual disabilities. I'm not expecting an answer now, but hopefully we could put something together there.
Absolutely, and we are happy because this is all publicly available information and it's meant to be public. So we are very happy to do whatever it can make them more read and reach the people who needs to be reached.
Great, many thanks. So thank you to everybody, well, Gerlinde and Eduardo for bringing those comments. Now we'll move in more into the national deployment of the COVID through or in different ways by the sector. We have four speakers coming from 4 areas of Europe. And let's start with in Finland, up in the north, in the snow, with Kirsi Kolola, who is CEO of the Service Foundation for People with an Intellectual Disability. Kirsi, how is the deployment going in Finland, and do you have any recommendations to make to other countries?
Hello, good afternoon to everybody. This time your introduction was correct. We are practically drowning into snow. There is huge amount of it this year. Indeed, deployment of the vaccines has occurred to be quite difficult topic here. It's rather surprising, but the coordination is there is huge lack of coordination when we talk about the deployment of vaccines to the practical level. There is quite clear introduction from National Health and Social Care Institute of how it will be applied, implemented in Finland. Of course, there is problems like lack of vaccines and so on, which can't be helped by coordination and things like this. But it's however it seems from the level of social services, it seems very disorganized, let's say. People with disabilities are not so clearly prioritized in the deployment system as people with elderly care. That's of course somewhat we understand, because not all people with disability are a risk group, of course, but this leads to a situation that it's really confusing for people with disabilities and their families, and of course also for services and staff. the implementation responsibility is on local level. And at local level, there is huge amount of confusion of priority groups and who are vaccinated when, and very practical questions in different areas of Finland are very accurate, and every day we are spending a lot of time around this topic. We are asking at the moment the NGOs and organizations of people with disabilities and the providers. We are asking for more clear instructions, but we don't know when we should get them. Basically the clear line of what's the deployment strategy of the National Health Care Institute is that people who are in 24/7 care get the vaccines. And so, of course, part of the people with intellectual disability especially are among this group. But then when we talk about the implementation of this general rule, there is a lot of different kind of understanding between different regions, because in some regions, the understanding is that only elderly care is among it, and so on. Of course, also dependent on how much vaccines there is, but then there rises huge amount of other questions, because of course not all people who need the vaccine are not in this kind of care model. There is also in other kinds of services, and there is a lot of confusion for them, as well as I would of course like to highlight the difficult situations the service providers are facing because of this, because quite in some regions, if the region sees that the people with the long-term care, also with intellectual disability, for example, are part of the prioritized group, then they might also see that people who take care of them are part of this group. But then also this strategy leaves out, for example, staff who works in respite care or daytime activities, and also people with really high support needs. And risk groups are, of course, using this kind of services. And then, for example, families are very concerned that they don't want to use the services anymore, because if the staff is not getting the vaccines in with the first wave, so to say, so this kind of strategies are not made clear, and that's the problem, I would say. Also, that in many areas, when we are asking about the local healthcare authorities about how, when, for example, our staff working with the risk groups gets the vaccines, they say that the occupational healthcare system is taking care of that. Then again, occupational healthcare system doesn't have any vaccines and not the prospect to get them anytime soon. So these kind of situations are, yeah, very not. I'm sorry, I can't give very positive positive picture of it, but this is really a big, very problematic area at the moment.
Thank you, Kirsi. I mean, it's not always about giving positive messages, it's also about giving the reality.
Yeah.
And if there's confusion, then we need to try and find solutions to that confusion. That's very important. And what I took is also the differences per region, of course.
Yes.
But also complexities in terms of, and what I've seen in many different countries, it's about those where you live is if you get the vaccine or not. And not so much the need for it, at least for within the services. So, for example, those in residential services would get it before others, but does that mean that they actually need it before others? And I think there were questions about that, which is very important. Thank you, Kirsi, and I may come back to you afterwards for some questions. But now to Switzerland, Peter. You run a large umbrella organization covering the entire country of Switzerland. How is it going? How is it going your side? Do you have any? Is it better than seems to be the case in Finland? Or I know you have a strong regional or canton-based system there. How's it going?
Hello, Peter speaking. Yeah, the situation, I think it's quite similar in Switzerland than in Finland. We have even snow here, and we have not enough doses of vaccine. So I think it's the same problem all over the world, not only all over Europe. I think we are in a prioritized situation in Europe than when we compare to countries in Africa or in other regions of the world. So to the corona topic in Switzerland. In Switzerland, the Federal Office of Public Health is the primarily responsible organization for the corona vaccination strategy. It's a national authority, and they, like I said, in many countries, too few vaccine doses are available also in Switzerland in the moment. And so a clear prioritization has been taken by the authorities. We have been consulted to this priority list, and I agree with it at all. You have to know, in South Switzerland, we have about 800 service providers as members, and they are all waiting for vaccine doses to start with vaccinate the employees and also the person with disabilities. So what is the prioritization in Switzerland? In the first priority are vulnerable persons above 65 years old or persons with pre-existing conditions. In the second priority are healthcare workers, caregivers for vulnerable persons. In the third priority are persons in close contact with vulnerable persons. And in the fourth priority, adults in community settings with increased risk of infection and outbreak with mixed age residents. So if you look at this situation, our sector is not really in the focus of these four priority, only with one exception. If there are persons with a high risk, then you can get these persons in the higher priority list. So what can we do? What is the role of the service providers? We say information, information, information. That is what we have to do. Documents have been prepared for the vaccination campaign, even in easy to read language. We at INSAS believe that a good communication campaign has to be prepared, is necessary to have, because we have a lot of skeptical persons, even young caregivers and employees, are also persons with disability are skeptical to this vaccination. So if you want to change this opinion, you have to inform them so they can choose what they want for their own. And secondly, for us, it's very important, the self-determination. It's the highest priority. There must be no obligation to vaccinate, neither for person with disability, nor for the supporters for the staff. But if we want that a lot of persons want to be vaccinated, we have to inform them. We have to give them the information that they can do their own right decision. So we have prepared good information, I think, for our members and even for the people with disability. We have developed a rather extensive list of questions with answers. So questions like, how does this vaccination work? Where can I get the information? Where I can be vaccinated? Who is in the higher priority? Can employees or persons with disabilities be forced to be vaccinated? What is the recommendation procedure for vaccinating people with disability? How you have to go to motivate them? And what does the vaccination cost? Who pays it, the vaccination? All these informations we prepared, and much of this information also have been prepared and made available in easy to read language. We communicate a clear position to service providers regarding vaccination of persons with disability. We have to be very careful there. And so we think it's important to have good information to educate this procedure to get vaccinated. It needs an explicit consent to be vaccinated, and we have to the self-determination I have said it has to come first. So we need to have the consent of every person that is getting vaccinated. We have prepared also a form which where the consent of vaccination can be documented. These forms also exist in easy to read language, because it's important for persons with disability that they understand to what they say yes or no, what are the consequences if they are vaccinated or not. And what we are looking very important is also there is a big hope with the vaccination, and everybody who thinks when I'm vaccinated, I'm free. And that is a really dangerous situation. As we heard before, even after vaccination, it's important to ensure that the protective measures continue to be applied. Because when you are vaccinated and you don't protect yourself and the others, it's not clear, we don't know it, that there is no transmission of the virus. And so as long we don't know that, we have to be very careful that vaccinated persons do not protect themselves after the vaccination. And I think it's necessary to have really a lot of motivation and information that this is convinced for every person to do that. I stopped my input with one last point that is discussing actually in Switzerland. The authorities have prepared mass testing. So even in situation for the service providers, it's possible to make a mass test of rapid test of the personnel, and even for the personnel with disability. And the motivation is very good to find all the persons who are infected, but also there we say it's necessary to have good information, and because not everybody wants to be tested, and even for person with intellectual disability, it's maybe hard to understand what is happening and why the test is necessary. And so there is also necessary to have good information in easy to read language. So I can say at the end of my words, it's important to have good information to motivate the employees, the person with disability, to follow the strategy of our authorities. So thank you very much. If you want to find information, you go to our website, www.insos.ch. You find coronavirus, and there you find every information, only in German and French, but maybe it's helpful for you. Thank you very much. Back to Thomas.
Thank you very much, Peter, for that. And maybe also you could double check our easy to read in French and German and Italian to check that they work also in Swiss German and Swiss French and Swiss Italian, maybe. Great, thank you. I'm sure there are many questions. I will now pass the floor to Dr. Einat Perry, who's from Beit Isi Shapiro in Israel. Israel is well known to be much more advanced in terms of the deployment of the vaccine than at least in most parts of Europe. And so I'm sure we can learn a lot, and also Mr. Patrick Levy will be joining her in the intervention. So how is the process taking place in Israel?
Okay, so good afternoon from Israel. My name is Patrick. I'm working at the Beit Isi Shapiro organization, which is one of the oldest organizations for people with disabilities, with many services, mainly in education, but also with a leadership center. And within the leadership center, we have cross disabilities groups. You can see the list right now. One of the groups is the Forum for Health of People with Disability, which is a forum of 22 women and men from all disabilities, from all backgrounds, from all age, from all over the country. And Einat is one of the members of this forum. And she's going to speak with you about the situation right now in Israel as we speak. Einat.
Okay.
Please.
Okay. First thing, I'd like to just tell you a bit information about Israel. The total population is 8.8 million people. We are a young country. We have 23% kids. We have two special populations, 1.8 million Arabs and 1 million ultra-Orthodox, which are less exposed to the media, which is very important for Corona. For people with disabilities, we have 1.5 million, including many children, and a third of which are above 65, which is direct risk for Corona. We are considered as an island country because entrance is mainly by air and can be controlled quite easily. It wasn't done, but it may be done. We have a very high level of free and available healthcare by 4 providers for all the residents. Okay. For these reasons, Israel was selected to be a model country by Pfizer, allowing very fast vaccination, and you will see the numbers. It's quite nice. We do have fragile political situation, which kind of really disrupt the way of the vaccination done. Current status in the face of the vaccination, we still have high morbidity and mortality due to COVID-19. Although we did have a lockdown of 1 month and it didn't work, we are optimistic and we hope that the vaccine will start working soon, because new cases now is roughly 8K per day, and the hospitals are starting to get too full. British mutation is 30 to 40% of the isolation, which is quite a lot. Rate of vaccinations in Israel for the moment is 2 to 3% of the population every day, which is huge, huge rate. 2.7 million people, 31% of the total population was vaccinated at least once, and 13% was vaccinated twice already. We also have 500,000 healed people that we don't vaccinate for the moment, though it seems that the new mutation might hurt them twice, might become a problem, and they might be vaccinated in a time. Next. A bit of epidemiology. The airports were really closed only yesterday. It means that all the mutations available are here and in high numbers. We started to see also the South African mutation running in the population lately. The British has a higher infection rates, higher mobility, and we see more and more patients in children and pregnant women that were not in the first year of the epidemic. So we consider it might be because of the British mutations, so look for it. We have a very high morbidity in certain populations, which I mentioned before, mainly due to low ability to inflict full lockdown on this population for political reasons. And it seems to have a connection also with the media exposure, because the regular population is more exposed to the discussion over the disease and the vaccines, and the vaccine rates amongst those two populations are lower than the normal population. Next. As for vaccines priorities, we started with a copy of the recommendation by the ECDC, which were very, very good. And we modified, how to say, on the run. First priority, we vaccinated health workers. And I'm very happy to say that we can already see a decrease in new cases of health workers. It means their vaccine is working. For first priority, we also have elders and their caregivers. It's very important to say whenever anyone is getting a vaccine, he can have his health worker, caregiver, given the vaccine at the same time. No question asked. They don't care if the caregiver is in another service provider. They don't care who is who. They vaccine the caregiver if he gets to the vaccination premises with the sick people. For first priority, we also added low lung reserve patients, immune suppressive patients, and for your information, people living in mental health institute, hospitalized, prisoners, welfare, whenever they cannot, the population is more crowded. And their direct caregivers were given vaccine the same time and in the same place. Next. For second priority, which is chronic conditions associated with severe COVID-19 sickness and school and kindergarten workers, and what is called first responders, the police, the regulation of the vaccination protocol demanded the health provider organization to create a special case committee. It means that anybody that thinks that is in a bigger risk than others can apply to this special case committee. Though I might say that this special committee was not talked among the people, so they can work easily without too much stress on the committee. Some pros and cons of the priority vaccination, prioritizing for the people with disability. First of all, as you know, not all people with disability are at higher risk. We gave the GP, the general practitioners, an option to choose who is in a greater risk and who is not. And if the GP could not do that, he applied to the special committee to do that. Most of the people with disability are at higher risk due to cognitive or mental issues or dependence upon health were vaccinated at the first priority. They are already vaccinated. And special cases, I told you, allowed by the committees. We have seen problems with rare diseases and conditions that are not very well defined, such as chronic fatigue syndrome, that according to the specialists, is at risk, but GPs in Israel don't know this disease very well, and they didn't forward it to the special committee. Next, I discussed that. Due to the fast vaccination rate and short time of preparation, first of all, I must state that home-restricted patients only started these days to be vaccinated, though the risk for them might be the highest. The problem is that Pfizer vaccines is not very easy to travel to the patient home. So we use Moderna vaccines for that. The Moderna just arrived in these days, so that's why it was delayed. Also, there is no special routine for fragile patients. As you've seen in Sweden and also in Israel, patients that are very sick and in very old age, let's say 90, 85, might get very sick and even die from the vaccine itself, not because of a real side effect, but only because they are too fragile to go to the vaccine premises, go back and kind of handle the vaccine stress. So
sorry, Inet, you have 2 more minutes.
I don't need 2 more.
Okay, perfect. Thank you.
Thank you. So I think it would be better to vaccinate these patients under hospitalization. Also, we have seen that since the demand for vaccination was very high in Israel, some vaccine premises allowed too many vaccines to be done. I mean, less prioritizing, and some of them were too strict. So you have to find the even way in between. That's all from my side. Thank you for listening.
Thank you very much, Dr. Einat and Patrick, for that overview in Israel. I think important progress is being made, but of course, more to come. That seems to be the way it is with COVID. You think you're reaching an end, but then you see more issues, more problems appear. But thank you very much for that overview. Last but not
sorry, if I can comment,
please do.
Just forgot something to say that will make people here happy. I think the preliminary index from Israel may show that the vaccine would stop the infection. I mean, it would be nice. It will not. It prevents the infection of others.
That's good news to hear. Yeah. Good to finish on a good note. Thank you, Doctor. So now I will move to Austria and to Petra Meerhaus. I hope I pronounced it correctly.
Almost.
Petra, the floor is yours.
Yeah, thanks. Yeah, thanks for having me here talking about the vaccination in Salzburg, Austria, organization Lebenshilfe Salzburg. How was our start? So we had a lack of information. Still, we tried to do some project management. We formed a team and even a sub-team for communication and tried to do as many steps as possible without a lot of. We focused, as I said, also on the communication and tried to prepare information about the vaccination for all our employees via different channels and also some easy to read information. The local teams informed the service users with these easy to read information and just a lot of talking and supported them in their personal decision making. We wrote letters to the families from the CEO himself, and we also offered some Zoom events. They were a real success, and we had like 5 events for different target groups and many participants, and they had the chance to ask medical questions also. And there was a presentation of our intern doctor. Our next steps were that we unexpectedly got the possibility to order very early via the federal online shop. So that was because the staff and the people with disability in residential facilities got priority 1. So we tried to make a schedule when and where we want to do the vaccination in our different at our different locations. But of course, there were limited amounts. So I had to do a rough estimate of the needed vaccines for every different location and then order that directly, very early, very fast, without really knowing how much we definitely need to be delivered to the different locations on different days. Then an important part of the preparation was that we needed the declaration of consent of every single person, so employee and also the service users. And if they were not capable of making their own decisions, there were the legal representatives and, for example, family members involved to help them or make the decisions. And then they had to sign some forms. We prepared our database to be ready for the documentation about the COVID-19 vaccination. Then we could make the calculation of the really needed based on the database entries. And then I organized the transport and logistics to all the different locations in our region. The implementation itself worked really well, or is still working. We make the vaccination at the residential facilities, and therefore we have some teams with always a doctor, a nurse, and an assistant for the documentation. So we don't need external staff to do that. And we combined the vaccination of the service users and the employees, but we just could not handle to also do it for the relatives, even though they would like to add that as well. And we had, or still have, 3 teams at the same time at different spots, and up to 25 vaccinations per team per hour. So some of the doctors are really, really fast, because we have prepared a lot of information before, and all the decision making was before that. What challenges do we face? There was a change of responsibilities, like right in the middle of it, from the federal to the regional authorities, which was connected with my access to the online shop just disabled in the middle of my ordering process. And like all the others, not enough vaccines for all the planned facilities. So we had to make some decisions, what's first and what comes next, and always the uncertainty. The current situation, about 85% of our service users are willing to get vaccinated, and about 50% employees, but that's rising at the moment. So by the end of the week, we got 730 people of our organization vaccinated, and we're really happy about that. And then we can wait for the second dose, hopefully coming in February from BioNTech Pfizer again. And we're still waiting for more information and more vaccine to come in the next weeks. What can I recommend to everyone who is organizing that as well? Be sure to really know who is allowed to sign the forms and to agree to the vaccination. That will take a while. And that is a challenge for all the people really working there at the different services. Provide enough reliable information, not too much, but just the really like enough and the reliable ones, to employees, service users, and their families. Also provide the possibility to ask some medical questions in advance. Do some networking to get all the information that is somewhere out there, and prepare to know how to use the leftovers, because if you open one bottle of the vaccine, you have to do like 6 or 7 vaccinations. So be prepared to know who to call if there is something left over. And find out what kind of documentation is needed in your case and what you have to prepare for that. Yeah, that's from my side. Thank you, and I'm open for your questions. We don't hear you.
Sorry, it seems like I'm. It was interesting to see how you did the process internally through your own doctors, through your own professionals who maybe have more expertise in dealing these specific situations. That was interesting to see. We have now time for a small discussion, and I can see it being quite active in the chat box. And Jim mentioned, let's say, some more complex, potentially ethical issues about what if, for example, a support worker refuses to get vaccinated, and that support worker works with a person who may or may not be at higher risk of COVID. How do you deal with that situation, in particular from the perspective of the employer? How does the employer deal with that professional or with that situation? How can we find a solution? Maybe Kirsi, do you have some ideas first?
Yes, I can say something regarding it. Of course, first I would like to underline maybe that in our country, the situation in the field of service providers working in the social sector, the capacity is quite different. What was described, for example, my colleague Petra previously from Austria, that we are not allowed to provide this kind of healthcare in social services. But of course, I fully agree that the values and this kind of self-determination aspect is quite important, especially when we talk about people in long-term care and living and so on. Of course, we want to support our for our people with disability living in our services. We support their self-determination. That's what the staff has to do, and to give, of course, not always so simple with people with intellectual disability, and I have to underline that we are supporting people with really high support needs, so also with high risks, of course. So the decision is always by them, of course, made. So they need support in making that decision. Of course, the system who is giving that support, that's on place, but to get enough information, that's our role basically. We see it that to give enough information, and that has been quite difficult so far, because we don't have, for example, of course, people are interested of very simple things. Where can I get it and when? And those are the two things we can't say to them. So it's quite complex to give them the answers they want, because they are very, very concrete things. Of course, people would like to know about with intellectual disability, but we try, of course, by the measures we have to support their self-determination. With the staff, it's of course different. We have a high recommendation that the staff working with the risk groups, like our service users mostly are, take the vaccine. But of course, we don't force anybody to take it. It doesn't have any impact on the conditions of work and so on if they don't take it. Like already mentioned by some of the colleagues, the number of people who are willing to take it it's rising all the time, of course, when we have more information and so on. First people were quite critical, as I think everywhere in Europe, but now it's yesterday it was a statistics that more than 85% of all population would take the vaccine if possible. We don't have exact numbers of social services, but I believe it's higher than that. So of course there are risks, but I believe that our staff by education and training and the values we work, they don't, even if they have personal kind of decision that they don't want it, of course, I believe that they are able to leave it behind and give the informed choice, opportunity to make informed choice for the person with disability. Of course, that's always happens in everyday life, in all the discussions and what's going on in the everyday life of the services. We are not able to monitor all that, but but that's what we try to give is to support informed choice of people living our services, and to let's say recommend strongly our staff to take it. That's the situation.
Yeah, thank you, Kirsi. So strong recommendations, but not obligations to staff due to some responsibilities they may have. But for the people who use the services, then it's all about informed decision making and making sure that process is correct. Peter, I have another question for you. It's quite common that people with intellectual learning disabilities have, let's say, unequal access to healthcare compared to, let's say, the general population in normal times. And does this, under the COVID situation and the vaccination process in particular, has this affected the vaccination deployment? The fact that many people with learning disabilities don't have equal access to healthcare system?
Thank you for the question, Thomas. Maybe first the ethical problem we discussed before. It's really an ethical problem, and it's not new. Even by the influenza virus, the vaccination against the influenza virus, we have every year this discussion employees or even persons with disability being forced to be vaccinated or not? And we have to pay attention that there is no stigmatization of persons who are not vaccinated. And we could observe in Switzerland, there was a stigmatization of persons who had the virus. So persons who have been positive, there's this stigmatization because they made a mistake to be infected. And so they are bad guys. And so we have to be very careful that the stigmatization starts with this new situation of the possibility to be vaccinated or not. So we think it needs to be to have good information and to motivate. We don't even recommend. We try to recommend to motivate the person with disability and the staff to be vaccinated. But the decision, it's really a personal decision. Every person has to make on his own side. And now to your question, Thomas. Yeah, I think in the moment we don't have the problem that persons with disability don't have the same access to vaccine, so, because when they are not vulnerable, they don't have the access as like other persons who are not persons with disability. So that's the problem in the moment. Most persons in Switzerland don't have access to the vaccine. It's only a small part, and it starts now. The vaccination is starting, and I think that is the role of the service provider to ensure the access to medical services for persons with disabilities, so that they have the same rights than every other person. The question is when a person is positive. And we had the situation in November in Switzerland where it was necessary to make a triage. We don't had enough beds in hospitals, intensive care beds, and we discussed: what are the criteria, and is disability a criteria that a person has no access to the last bed in the hospital? Or is it only the age? And that was a long discussion and with the authorities, and we reached together with the organization of persons with disability that the situation of disability is not allowed to be considered as a criteria to have access to a bed in a hospital. But I think in the common population, I'm not sure if they would decide in the same way. We discussed it even in other areas. The ski station in Switzerland are all open, and if we have one bed in an intensive care hospital, one bed, and there is coming a 35-year-old woman after accident in ski, and she needs to be cared in intensive care, and you have on the other side 72-old man who has coronavirus and need this same bed. Who decides with what criteria which person gets this bed? The discussion was not so clear, because the young said, yeah, that's life when you get older. So the younger person has the priority. And our opinion was, no, in the moment, it's not good to go skiing and to make dangerous sports. But that's also an ethical and a discussion in the society. What is more important? And so it's very dangerous, not only for a person with disability, even for person over 70, over 75 and 80 years, not to be declared as person of second or third class in our society. So it's a very dangerous situation.
Absolutely. Thank you, Peter, for that. Now, one last question. I think there was one specifically by Brigitte, which was targeting, I think I'm trying to get it back again now. So the question is for Einat. In Israel, are family carers also considered as caregivers when they accompany a relative who is vaccinated? I don't know if you could provide some input about that. So what the situation of family carers?
So it's quite easy. Whenever disabled people is getting a vaccine, he can get whoever he wants to get vaccine with him. Actually, when I got mine vaccine, I didn't get mine, but it's another story. I took my husband and my foreign worker, and both were considered caregivers and were vaccinated for me.
Okay, thank you, Ina. Clear response. And now I would like to also give the chance to Petra. Maybe she has some on some of the discussions and the issues that have been commented. Would you like to come in on any of the points?
Not right now, thanks. No.
Okay, great, thank you. So thanks to all the speakers today for your valuable contribution. I will now pass the floor to ESPD President Jim Crow for some concluding remarks. Jim, the floor is yours.
We only have a couple of minutes left, but I think I would like on your behalf as participants to thank our panelists. I think they have created many thoughts in my mind, and I'm sure in your minds as participants, about how we approach vaccination. So I think we go away from the webinar without clear answers, but lots of things to think about. I'm conscious that for many of us in our countries, this issue is still a little bit theoretical. Vaccine supplies are very short, and we need to get them quickly into our countries. But I live in the UK, and even, I mean, amongst the many failures of the government in this country, the only success at the moment seems to be the vaccination approach. And vaccination happening for many people. But, and the big but is that there are about 8 priority groups in the queue for vaccination. And the prime factor for determining access to those priority lists is age. Age plus frontline health and social care workers. So healthcare workers and social care workers in care homes are getting vaccinated, as are older people. If those people have a disability, then that means they get covered because of their age. I think it's about priority 3 or 4. You are in that category if you have what are described as underlying health conditions. And they do put people with Down syndrome into that priority. But otherwise, people with disabilities are not in the priority list unless they have an underlying chronic health condition. So there are issues there, and that's despite evidence in the United Kingdom that people with intellectual disabilities have suffered disproportionately and died disproportionately from COVID. So I think there are challenges in each of our countries as vaccination is rolled out about how we lobby and push for people with disabilities to be vaccinated. So I think we go away from this webinar with a lot more information on our minds. I think some of the ethical issues are there for us to think about a little bit more. But I hope you found this webinar valuable. I certainly have. And again, thanks to all the panelists and to the people corresponding in the chat boxes. I gather that all the presentations will be available. I don't know if you want to just emphasize in conclusion, Thomas, how that will happen. But please, everybody, thank you for your participation, and I will say goodbye. Thank you. Thomas, did you want to say a word about access to the PowerPoints?
Absolutely. Well, of course, I will need to speak to each panelist in regard to the presentation. I do assume, maybe a bit cheekily, but I do assume that they will be available to share publicly. So once that process is done, we will make sure that they are available both on our websites, together with our easy to read in the different languages. But we will also be emailing each of the registered participants afterwards and share all the relevant documents with them. Again, one last call to people if they want to help translate our easy to read documents into additional languages. We really want to reach all relevant languages, at least within the broader European continent. So please contact us if you can help. And then we will, of course, be in touch with the EU institutions in terms of their vaccine strategy to try and raise many of the issues that we have discussed today. Because although it is theoretical in many countries, very, very quickly before we know it, hopefully it will become a reality, and we need to make sure we do it in the right way. I think many of our colleagues, in particular in Israel and in Austria, have shown how that can be done. So hopefully that brings some inspiration to this discussion. And also many thanks to the ECDC for recommending quite clearly how this can be done in a very statistical way. Maybe potentially in the next few weeks and months, we could discuss how to better integrate the disability angle within this discussion with them. But thank you very much to the 110, 120 participants who have followed us today. It's been a pleasure, and I wish you a lovely afternoon. Bye-bye.